All right, guys, so we're going to talk about vital signs, and this is really just something more to talk about the monitoring devices and types of vital signs because it's difficult to explain this to you through a video, and so we'll actually be practicing this at your next in-class session where we can actually see and teach you how to do these vital signs. So why are vital signs important in the first place? Well, they are the outward sign of what's going on inside of the body, and they're going to help us identify what's going on with the patient. Are they improving? Are they deteriorating? And we're going to gather them on basically every EMS patient that we come into contact with. So if it's a medical patient, if it's a trauma patient, we're going to get those vital signs. Even someone we might get a refusal on, we're still going to probably get a set of vital signs. So again, occasionally the severity of the patient might prevent some of these from getting taken on every single patient, and it really just kind of depends on what's going on with them. A full set of vital signs will include all of these things, and so we'll break this down and talk a little bit more about each one and why they're important and who would be the best candidate for these. So there are two types of vital signs. You have your baseline vital signs and then repeat vital signs. So the baseline is going to be that very first set, and that's going to be what we're basing everything else off of. The rest are going to help to get us a trend. So again, not just one set of bad vital signs or not ideal vital signs, but is the patient trending in the same direction? Do they appear to be deteriorating? One bad blood pressure or blood pressure that's too high is not as bad as multiple trending vital signs over a period of time for transport showing the patient is truly getting worse. So first, let's talk about the pulse. So the pulse is the palpable pressure of the heart beating when the vessels are constricted, and we can feel this by placing two fingertips over an artery where it lies close to a bone or over a bone close to the body's surface. So we should never use your thumb because you can hear your own pulse or feel your own pulse in that. So we're usually going to use our index and middle finger to be able to assess a pulse. Common sites that we're going to use most often are going to be that carotid site for an adult patient, the brachial site for a child that's under about a year or so old. We're going to be checking the radial site a lot for adult patients, and then depending on what's going on, we might use the femoral and then also the dorsalis pedis or posterior tibial, as we talked about during patient assessment for getting those distal pulses as well. Things that we're looking at with the pulse is going to be the rate, the rhythm, and the quality. So the rate is going to be the number of times the heart is beating per minute. Now, normal for a healthy adult patient is between 60 and 100 beats per minute. Now, that's going to vary based off of each individual patient and also the patient's age. Young people, especially small children and infants, are going to have a much higher heart rate. That's what's normal for them. Anything over 100 is called tachycardia, and anything under 60 is called bradycardia. And so we're used to seeing those terms tachy and brady, meaning too fast or too slow. Now, rhythm is pretty self-explanatory. Again, is it a regular interval between beats or is it not? So is it regular or irregular? And then what's the quality? So normal is strong. If it's bounding, then that might mean they're higher pressure. Their arteries are under higher pressure. So again, bounding should not be normal. Strong, easy to palpate is normal, but not bounding. If it's weak or thready or difficult to palpate, that could be or show us that the patient has inadequate perfusion or inadequate blood pressure. If you have a palpable blood pressure or a pulse at the radial site, then that generally means that your blood pressure is at least 80 or 90 systolic, depending on what literature you're looking at. And so that's good. If this is a trauma patient that I just simply do not have time to stop my assessment and check a blood pressure on, and I feel that they have a palpable radial pulse, that's good enough for me. That I would document that in my report, but that's good enough for me. I don't need to stop and check that blood pressure right now. I know they've got a radial pulse, so I know they're good for now. Other things to consider when you're counting the pulse, if you don't have time to stop and count it for a full 1 minute, you can count it for 30 seconds and then multiply it by 2. You don't want to get down into counting it for 15 and multiplying by 4 or anything like that. So usually 30 is a good rule of thumb. If there's an issue with the rate, the rhythm, or the quality, then we would go ahead and check for the full 60 seconds and compare the carotid and the radial site just to help help identify any potential problems that are there. Again, we said the most common pulse sites for adults are going to be that carotid site and also the radial. Most common sites for infants and small children going to be the brachial site. The femoral site we mentioned, that would be used most likely during a cardiac arrest, just because there's a lot of stuff happening up near the head of the patient. And so that gives us a little bit easier and less interrupted access if we're checking at the femoral site. Talking about respirations, so remember when we talked about the human body, we said that when we're breathing air in and out, we call that ventilation. And when we're making an oxygen exchange, we're calling that respiration. But in regards to vital signs, I am in fact talking about the number of breaths that each person is taking per minute when I say count their respirations. So things we're looking for here, the rate, the rhythm, and the quality. Now, the easiest way to check the person's respirations is going to be to kneel down as if you were still continuing to check their pulse, and keep your hand on their wrist there, and just go ahead and now for the next 30 seconds, count their respiratory rate. Because if you tell them that you're going to be counting how many times per minute they breathe, what are they going to do, right? They're going to alter that. They're going to take a deep breath. They're going to slow it down. They're going to pay attention to it. So you're not going to really get an accurate reflection. So we're looking for rate, rhythm, and quality. Rate, again, being the number of breaths per minute. Regularity, meaning is it happening regularly? Is it not happening regularly? And then rhythm, meaning, rhythm meaning is it regular or irregular, and then we're also going to talk about quality in just a second. So as far as rate, again, just like with the pulse, if this is an adult patient, what's normal is 12 to 20 breaths per minute. A little faster if you're younger. Infants can breathe up to around 60 times per minute and still be okay, but that's certainly not self-sufficient for an adult. Anything over 20 breaths per minute is considered tachypnea, so there we see those medical terms again. And anything less than 12 is considered bradypnea. But again, remember, as we said with patient assessment, we're not getting too concerned unless we're in that less than 8 or greater than 28 range, where we might need to consider ventilating the patient. Looking at the quality of the patient's breathing, that's going to be what's normal. All right, we have good chest rise and fall, and we got average depth, no accessory muscle usage, patient's not struggling, they don't have to sit in a tripod position to breathe normally, everything's going okay. If the patient is breathing more shallow, then that could be a concern for us, especially if it is slow and shallow. Generally, when it's shallow, it becomes more rapid. We're looking to see, is it labored? So is the patient sitting in a tripod position? Are they grunting? Do they have nasal flaring? Do we hear anything that's abnormal? Do we see them physically struggling? And then some other things that we might hear would be wheezing, gurgling, stridor, snoring. These might be, depending on where they're located at and coming from, something that we can correct. And so we'll kind of talk about that in just a second in regards to lung sounds, what those mean. But upper airway sounds, like if you hear snoring or gurgling, we might need to reposition the patient's airway because that would not be open and patent. Like we said, if we're going to be assessing respirations, best way is going to be to pretend like we're still checking the pulse and not alert the patient to what's going on here. If you have difficulty in watching that chest rise and fall, maybe place your hand on the patient's back just so that you have an easier time watching or feeling your own hand rise and fall. With lung sounds, these are just a few of the most common. So when you're listening to a person breathe normally, you should hear air moving in and out of the lungs. Now, you're not going to hear any drastic sounds. It's a very quiet movement, but you should hear something. If you hear absolutely nothing, then that's bad too. That's a silent chest, so we should hear something. But these are some of the most common abnormal findings, and that's wheezing, stridor, and rales. So if a person is having wheezing, that could be indicative of like COPD, asthma, bronchitis, or anaphylaxis. And basically what that means is that the alveoli and the bronchioles, they are constricting. All right, so something is causing them to constrict, and that could be from a spasm, it could be from chronic sickness. It just really depends on what's going on, and the general treatment here includes bronchodilators or something like albuterol treatments. So remember that this narrowing of the bronchioles is a lower airway obstruction. All right, so we're going to get ready to talk about the difference between upper and lower airway obstruction. Remember, in the human body, we said anything above the trachea is considered upper airway. So from the trachea down, this would be a lower airway obstruction. The other sound we're going to hear for a lower airway obstruction might be rales. All right, so that would be indicative of pulmonary edema or congestive heart failure. It could be coarse or fine, so very loud or very quiet. You hear this more like a bubbling sound. All right, that's what rales sounds like. So you might hear some wheezing above that bubbling, but if you hear the bubbling at all, we should not treat that with a bronchodilator, and we'll talk more about why that is in the pharmacology side of things. So the treatment for that rales is going to be CPAP, which you can do at the EMT level, but you might need some ALS assistance just depending on your individual county that you live in. So those are lower airway sounds. Now, in upper airway obstruction, we might hear stridor. And so you could hear this for a lot of different reasons. It could be anaphylaxis that's causing a swelling in the airway. It could be swelling from burns. It could be some type of infection there like croup. It could be an actual foreign body that's blocking the airway. But whatever it is that is blocking that passage of air, constricting it, is causing this high-pitched whistling sound, and that is an upper airway obstruction. Now, depending on what it is will depend on what type of treatment we need to use, whether we need to just simply moisten the airway with nebulized saline, if we need to administer epinephrine for anaphylaxis, if it's a foreign body and we need to remove it, whatever it is, then we're going to talk about different types of treatment there. But just understanding the difference between upper airway obstruction, lower airway obstruction, and what kind of sounds we might hear. So I'm going to stop here, and I'll catch you guys in part 2.